Started. Welcome back, guys. Welcome back, guys. Today, let's discuss about the female genital pathology. Okay. So now in this today's class, mic full. Just 1 minute, guys. Okay. Yeah. Okay, guys. Now in this class, we'll be discussing about the genital pathology, especially the female genital pathology. Now in this class, I'll be mainly concentrating on three topics. Okay, three main topics. 100% I can assure you that 3 questions will be coming in your exam for sure. Okay, these 3 topics are also going to be interrelated with the gynecology, obstetrics and gynecology. Here in pathology, what are the important things which you should know? Okay, I will be discussing those points which will be important from pathological point of view. Okay, so without any further late, let's begin with the cervical cancer. Okay, the first important topic that I want to discuss here is the cervical cancer. I have already made a video on cervical intraepithelial neoplasia and cervical cancer from OBGYN point of view. Like, what and all the things which you need to know for OBGYN, I have already made a video, I think almost 1 year back. There is a video available in the YouTube. You can also check that video out. Okay, so there I have also integrated with the OBGYN where I have discussed everything. Okay, 100% in your exams there will be one question coming from the cervical cancer, no doubt in that. Okay, no doubt in that. So without any further let's begin with the cervical cancer. Now say, before going to discuss about the cervical cancer, okay, before discussing about the cervical cancer, the point which I want you to know is, see, there is a region. Okay, now here I am talking about the cervix. See, here you are seeing the cervix. Okay, now here the red color region, whatever you are seeing, okay, whatever I am highlighting here, the red color zone, this zone is called as the endocervix, means more towards inside, that's called as the endocervix. Okay, okay, next, so the cervix which is more outside, okay, the cervix which is more towards the outside, this pink region is called as the exocervix or ectocervix. Okay, and the cervix and the cervical region, I should say, which is present here, this whitish area, little whitish area, okay, that is called as the transition zone or the transformation zone. Okay, so here I have discussed about the 3 parts. Okay, in a cervix there is exocervix, there is endocervix, and there is a transformation zone. So why this is important is because it's a transformation zone that's going to be most commonly affected. Okay, both in cervical intraepithelial neoplasia, I will discuss about that, what it is. Both in cervical intraepithelial neoplasia, which is a pre-cancerous stage, and in cervical cancer, which is actually a cancer. Okay, it's a cancer, cervical cancer, it's a malignancy, and pre-malignant state is cervical intraepithelial neoplasia. In both the conditions, it's the transition zone that's going to be affected. Okay, so the first important point is, it's a dynamic point. Okay, it's a dynamic point. It moves with age. I have said you what is a transformation zone. I have shown you what is a transformation zone or the transition zone. The place where the endocervix is converting into the exocervix. The endocervix is converting into the ectocervix. So let me show you here in the histology. See, here you are seeing the squamous epithelium. Okay, squamous, stratified squamous epithelium. Now here you can see the columnar epithelium. See, the columnar epithelium is present in the endocervix. So endocervix have columnar epithelium. The ectocervix have squamous epithelium. So in between them there is a zone of transformation from endo to exo. So this transformation zone is the most common site. Okay, that's the most common site for the cancer to develop. And this transformation zone, that white color area, whatever I have shown here, the transformation zone, it's a dynamic point, which means it changes with the time. Okay, it changes with the age, it changes with the different hormonal conditions, it changes with the pregnancy, means the location is going to vary, the location is going to change. So it's a dynamic point, it moves with the age and hormonal influence. Usually with age, it goes more inside, okay, moves inward into the endocervix with age. But It moves outward during pregnancy. During pregnancy, what happens is this transition zone is more exposed out. So if the transition zone is more exposed out, there is a chance that it can get the infection, and there is a chance that it can lead to cervical intraepithelial neoplasia, that it can convert into the cervical cancer. So pregnancy is one of the risk factor for getting the cervical cancer. Yes, during pregnancy, there is more outward movement of the transition zone. As it is more outward, there is a chance that it can get the viruses like human papillomavirus, which is the most common cause of the cervical cancer. Okay, so pregnancy, and during puberty also. During puberty, it is more exposed out, it's more externalized. And OCP users, oral contraceptive pill users. Okay, so in all these conditions, the transition zone is more externalized. So there is a risk of cervical cancer. Okay, so I have already mentioned you, it is the most common site for cervical intraepithelial neoplasia, CIN. For those students who doesn't know what is CIN, CIN means cervical intraepithelial neoplasia, which is a pre-cancerous stage, pre-malignant stage. And cervical cancer, for both the CIN and cervical cancer, it is the most common site. I want you to know the CIN is the one which is going to convert into cervical cancer. First, the patient is going to have the CIN. With the time, the CIN will be converted into cervical cancer. What is the location, sir? Where exactly is this transition zone located? Okay, the transition zone is located 1.7 to 2.3 centimeters from the external os. This is the external os, right? There will be two os. Cervix has two os, internal os, external os. So 1.7 to 2.3 centimeters. Actually, this is a question. 1.7 to 2.3 centimeters away from the external os. There's going to be this transition zone away from it. Okay, done. Next. Here I have very clearly shown endocervix is in red color. Very clearly I have shown here the endocervix is in red color, the exocervix is in pink color. In the white zone, that white zone which I have shown here is the transition zone or transformation zone. Now, let me explain you the classification of the CAN. Okay, the classification. There are actually two types of classification, WHO classification, okay, and Bethesda classification. WHO and Bethesda classification. What is WHO classification of CAN? Let me explain you in a very simple way. Okay, see, for example, here I am showing the, for example, imagine this is the cytology in the cervix. Okay, this is the cytology in the cervix cell. Okay, now see, the patient is acquiring this virus, HPV virus. Okay, the HPV virus is the most common cause for the CAN as well as for the cervical cancer. Okay, now the patient is getting this HPV virus. Now you can ask me how the patient is getting HPV virus, sir. Maybe she is a commercial sexual worker, she is having a promiscuity, so she is acquiring this HPV. HPV is like, sexually transmitted disease. Okay, it's a sexually transmitted virus, HPV. Okay, human papilloma virus. Once this human papilloma virus enters into the body, the cervical area, see, it's going to affect this basal cells, especially the basal cells are going to be affected in the cervix. Okay, now see, only the lower 1/3, okay, here is the basement membrane, for example, take it. If only lower 1/3 is getting affected, means the cells are showing the dysplasia. Now these are not the normal cells, these are the viral infected cells. Now these cells which are infected with the virus are going to have a very big nucleus and perinuclear halo. So there is a dysplasia that is seen. So these cells are called as the coelocytes. Okay, so the cells which are affected with the virus, the cells are called as the coelocytes, and the lower 1/3 is affected. You understood? So this is called as a mild stage. Okay, CIN1, cervical intraepithelial. The name itself it say. See, that's dysplasia is still within the cells. Okay, intraepithelial. It's not getting metastasized. Once it is metastasized, it's a cancer, definitely. Once the basement membrane is broken, it is a cancer. But here only lower 1/3 is affected. In CIN2, almost 2/3 is getting affected. In CIN3, almost affected, sir. Okay. In carcinoma in situ, see, from here, it's a carcinoma in situ. We are calling it as carcinoma, where the total, like, the cervix, okay, the total length of the cervix is getting affected with the cells. Okay. So this is called as a carcinoma in situ, and you can very clearly see here, once the basement membrane is broken, now it is cancer, now it's invasive carcinoma, it's a cancer. So at the end of the day, what I want to put into your mind is, according to the WHO, CAN is classified into 3 types: mild, moderate, severe kind of thing. Okay, so according to the WHO, CAN is classified into 3 types. What are they? Mild dysplasia. means only lower one third is affected, that is CAN1. Moderate dysplasia, which means yes, the dysplastic cells are seen in the lower two-third of the epithelial lining, means lower two-third. And severe dysplasia CAN3, dysplastic cells are more than two-third. Okay, see in CAN3 it's more than two-third, almost. So that is CAN3. And in carcinoma in situ, I have said you it's a complete. Dysplastic cells are full thickness, and but the basement membrane is still intact. Look here, in carcinoma in situ, the basement membrane is still intact. Okay, so this is the point which I want you to know. Now in invasive carcinoma, yes, now it's a cancer. Invasive carcinoma means cervical cancer. Okay, so the basement membrane is broken. Now the cervical intraepithelial neoplasia type 3 is getting converted into cancer. Okay, so WHO classification completed. CN1, CN2, CN3. Okay, and the dysplastic cells are called as the coilocytes. Okay, now according to the Bethesda classification, this is the newer classification. See, according to the Bethesda classification, CIN1, 2, okay, CIN1 and 2 are coming under, sorry, CIN1, only CIN1. Okay, CIN1, that is a mild dysplasia, is considered as LCIL. Okay, so low grade squamous intraepithelial lesion. Okay, but CIN2, 3 and carcinoma in situ, all these are considered as the HCIL, means high grade squamous intraepithelial lesion. This is intraepithelial lesion. Okay, it's not yet cancer, it is a pre-malignant condition. So according to WHO classification, CAN1 to 3, according to the Bethesda classification, simple, LCIL, HCIL. CAN1 is LCIL, CAN2, CAN3 are HCIL, high grade lesions. Now you can ask me, sir, why they are considered as a high grade lesions? Okay, it's because, let me tell you, see, CAN1, CAN2 and CAN3, here I have shown you CAN1 to 3. So what is the chance of progression into the carcinoma? CAN1, okay, there is a chance of only less than 1% turning into cancer. Okay, if for example there is a female who is having CAN1, okay, she is having CAN1, means low grade intraepithelial lesion. The lower one third is having dysplastic cells. Now she getting into the cervical cancer, what are the chances that she will end up in the cervical cancer is less than 1%. But CAN3, okay, so there is a 20% chance that in the future she can develop cervical cancer. Okay, so this is a high grade lesion. So high grade lesions, but one is considered as a low grade lesion. Okay, so what I have explained you, two things, WHO classification, Bethesda classification. Okay, this is a MCQ. There is a 20% chance that CAN3 can actually turn into a cancer cell. Next, what else you should know? What are the predisposing factors for the CAN and cervical carcinoma? What are the predisposing factors? Who can get this cervical intraepithelial neoplasia followed by cervical cancer? See, HPV infection, see, 99% of the time HPV infections, human papilloma virus infection. There are types, HPV 16, HPV 18, there are subtypes. We will discuss about that later. HPV infection is the most common. Now, intercourse before the age of 16 is also considered as the risk factor, because at that time during puberty, the transformation zone is more externalized. There is a more chance that she can pick up the virus easily. Okay. Now, promiscuity means having multiple sexual partners. If you are having multiple sexual partners, there is an automatic chance that you can get these sexually transmitted diseases like HPV. Okay, there is a likely chance that you can end up in the cervical intraepithelial neoplasia. Okay. Next, multiparity. So multiparity means multiple pregnancies, like multiple deliveries, multiparity. More the times delivery, more the times the transformation zone is externalized. With more and more deliveries, with more and more vaginal deliveries, the transformation zone is externalized. That's the one thing. And not only that, during delivery, what happens is, when the baby is coming out of the uterus through the cervix, okay, now there is shedding, right? Okay, all the cells are going to be removed, all the cells are going to be shedded out. So there should be a replenishment. Okay, the cells are going to again divide and replace the lost cells. So during that process also, there is a chance that those cells can undergo dysplastic change and can lead to cervical intraepithelial neoplasia. Okay, poor socioeconomic status, poor hygiene. Poor socioeconomic status means maybe she is not having a proper sexual hygiene, or maybe she is a commercial sexual worker. Okay, because of the poor socioeconomic status, she can end up in getting HPV. Okay. Smoking is going to be immunodeficiency. Okay, smoking can cause the immunodeficiency, and that can lead to getting viral infections very easily. Okay, are any immunocompromised states? OCP usage, I have said you OCP users can also have the externalization of the transformation zone and in utero exposure to diethyl silvestrol. Okay, this is a drug, sir. This is a drug, diethyl silvestrol. So what this diethyl silvestrol is going to do? Diethyl silvestrol is going to cause congenital malformations in the female reproductive tract actually. Okay, so diethyl silvestrol, it causes the malformations. One such malformation may be the cervix is more externalized, is more like the transformation zone is more outside, so it can easily pick up the infections. Okay, can be possible. So postpartum, like postpartum period, I have said you the cells are more like the cells are regenerating. Okay, the cells are dividing and regenerating. So in such cells, there is a possibility that they can pick up the dysplastic changes. Okay, postpartum, the cervix, the transformation zone is more externalized. So these are the risk factors, sir. The most important risk factors which I want you to know is, say, HPV infection. Okay, HPV infection, promiscuity, multiparity, next OCP users, and postpartum. These are the most important things. Okay, next, after this, let's discuss some important points about the HPV. The human papillomavirus, yes, it's the most common etiological factor for HPV. Sorry, it's the most common etiological factor for the cervical cancer. Okay, next, what are the different types of HPV? There are many HPVs which can lead to the cervical cancer, but the most common is HPV 16. See, HPV 16 is going to cause which type of cervical cancer? It's going to cause squamous cell carcinoma of the cervix. Squamous cell carcinoma of the cervix. HPV 16 is going to cause squamous cell carcinoma, but HPV 18 is going to cause adenocarcinoma of the cervix. Okay, so there are two types of cervical cancer. One is squamous cell carcinoma of the cervix, adenocarcinoma of the cervix. 16 is going to cause squamous cell carcinoma, 18 is going to cause adenocarcinoma. Apart from that, the most common, if they ask you, what is the most common virus causing cervical cancer? 16. What is the most malignant and most specific? Okay, most malignant. A lot of chances that once you get it, there is very much chance that you can end up in the cancer. So most malignant and most specific is HPV 18 causing the cervical cancer. Which type of cervical cancer? Adenocarcinoma of the cervix. So I have said you 16 going to cause cervical squamous cell carcinoma, 18 going to cause adenocarcinoma. Okay. Now, what is the most common age group for getting this CIN and cervical cancer? The most common age group is going to be the reproductive age groups. Reproductive age groups, more chance of promiscuity, more chance of the sexual transmitted diseases, more chances of getting HPV infection, more chances of CIN and more chances of cervical cancer. So that's the point which I want you to know. So it's mainly, I have said you, this HPV mainly it is affecting which cells? It is the basal cells. Okay, the basal cells are going to be most commonly affected first with the HPV. Okay, basal cells. So once the cells are affected, those cells are going to be called as coelocytes. Okay, coelocyte, and many cells are called as coelocytosis. Okay, so the cells which have became dysplastic because of the infection with the HPV, those cells are going to be called as coelocytes. Now some important points, sir. Why this HPV is going to cause cancer? How it is going to cause cancer is, sir, let me tell you one by one some important points which you need to know for your exams. Viral proteins helping in the adherence, okay, attachment. So this virus, once it enters into the body, it have to go and latch, okay, it have to go and latch onto the cells, right? For the attachment, it's having two important proteins which are called as L1 and L2. So L1, L2 helps in latching, attachment, okay. Viral proteins which are helping in the replication, okay, replication. So E1 and E2, okay, it helps in, E1 and E2 helps in the replication of the virus within the cells. And the viral proteins helping in the malignant transformation, E6 and E7. So these are all very much important. These are all previously asked questions. E6, E7 for malignant transformation, E1, E2 for the replication, and attachment is L1 and L2. But I have asked you, why this HPV is causing the cancer? How it is causing the cancer is, see, this E6 is there, right? E6 and E7. It's the one responsible for the malignant transformation. How? This E6, it inhibits the P53 gene. P53 is a tumor suppressor gene. Okay. So because of this, like tumor suppressor genes, these tumor suppressor genes are getting inhibited. These genes which are present within the cells, for example, say this is my cervical cell, for example, the patient's cervical cell. Okay, this is the cervical cell of a patient. Now, in this patient, in this cell, say there is a P53 gene. Okay, P53 gene as well as the RB gene, they are always inhibiting the malignant transformation. First, these genes are going to be inhibited. If you inhibit these genes, now the cells are more likely to develop the tumors. So simple as that. So L1, L2 for latching attachment, E1, E2 for replication, E6, E7, which proteins are responsible for the malignant transformation? It is E6 and E7. Okay, I have said you which cervical, like which pre-malignant condition. Is it C1, C2 or C3? It's the C3. Okay, if the patient is having C3, there is a 20% chance that the patient can end up in cancer. Okay, so done. What else you should know in the pathology? Okay, this is the main important part for the pathologist. Okay, so what is the screening test that is done for the cervical cancer? What is the screening test? See, the screening test is going to be pap smear. Okay, the screening test is pap smear. Okay, the screening test is going to be pap smear, sir. Okay, so screening test is going to be pap smear. Now, the point which I want you to know is, see, every female, okay, it doesn't matter regardless whether she had intercourse or not, every female from the age of 21 years, she have to take this screening test. Okay, she have to take this screening test which is called as a pap smear. See, what we are doing in this pap smear, look, the times for the pap smear is 21 years. Regardless of the age of first intercourse, doesn't matter when she had intercourse at what age, she have to go for the screening test. What is the best time for the pap? It's a pre-ovulatory phase. Okay, pre-ovulatory phase. Okay, doctor knows, like, whether she have menstruated or not, like, she knows, right, like, her cycles. Okay, so pre-ovulatory, on the 14th day she is going to go for the ovulation. So pre-ovulatory phase, we are going to do the screening test which is called as a pap smear. So what exactly are we going to do the pap smear? See, what we will do is, see, here we just put a speculum. Okay, and now we are using this instrument, sir. We are using two instruments. So this instrument which I am showing you, this is called as Ayer spatula. Okay, this wooden stick kind of thing which I am showing you here, that's called as a Ayer spatula. And here this instrument which I am showing you, this is called as a cytobrush. By using these instruments, we are putting this into the vagina and we are taking it to the cervix. And what we are doing is, see, we are collecting the cervical cells. Okay, we are collecting the cells from the cervix. Okay, so this is what is nothing, this is what, see here, this is the Ayer spatula. Okay, so what are the instruments used? The instruments which are used are called as the Ayer spatula. Okay, which usually conventional method. This is a conventional way of taking the cells and looking for any dysplastic changes. And there is one more instrument which is called as the endocervical brush or cytobrush. Okay, cytobrush. It is used for more advanced thing which is called as a liquid based cytology. But at the end of the day, guys, simple. There are two types of instruments used. One is called as the Ayer spatula and the other is called as a cytobrush. By using these instruments, we are going to collect the cells from the cervix. After collecting the cells, what we are going to do? We are going to put it under the microscope and we are going to check for any dysplastic change or not. If she is having any little dysplastic change, we will tell CAN1, CAN2, CAN3 or carcinoma in situ. Okay, so we can know. Now, after getting the cells, okay, this is a question which was asked. After getting the cells via the pap smear, what is the fixative used? Okay, you have collected the cells and you have applied it onto the smear. Okay, now you have taken it. Now you have to put a fixative, right? First you have to put a fixative. Later on you have to put the stains. So what is the fixative used? This is the question. The fixative is 95% ethyl alcohol. Ethyl alcohol is the fixative used for pap smear MCQ. Okay, so you are going to prepare 2 slides and you are going to examine for any dysplasia. Now, some important questions which were previously asked. The women of age 21 to 29, okay, the reproductive age group, the main reproductive age group, 21 to 29 years. What they have to do? Once in every 3 years, they have to go for the PAP. Okay, once in every 3 years, they have to go for the PAP. Okay, now women of age 30 to 65 years. Okay, from 30 to 65 years. Now, they also have to go for the pap smear once in every 3 years. Okay, once in every years, they also have to go for the pap. But there is one more test which is called as a co-test. Now, in this co-test, what exactly we are going to do? In this co-test, we are going to do the pap. Okay, we are going to take the pap along with, we are going to check for the HPV DNA, if there is HPV DNA or not. If we do both the things, combined things, one is doing pap as well as HPV DNA. If we do both the things, then it is called as a co-test which is a better test when compared to the PAP. PAP is simple, like is a screening test. Now this is more better because we are doing the PAP along with HPV DNA. So if the co-test, if it is a negative, then you can go for the next test after 5 years. Okay, so the point is, when you have to go for the PAP, 21 to 29 years. Okay, this age group females, they have to take the PAP once in every 3 years. Okay, now age group of 30 to 65 years, this age group have to take the PAP again once in every 3 years. But if they go for the co-test, okay, they have done the co-test and it is a negative, then they have to take it again after 5 years. After 5 years, once in every 5 years. See, very important point is, every female have to go for this. It doesn't matter whether she is having promiscuity. If she says no sir, I am like not having any such promiscuity, doesn't matter. Every female have to take this according to the guidelines. Every female have to go with the pap smear. Okay. So if after 65 years, now she is 65 years old, the likelihood of getting the cancer, okay, cervical cancer at this age group is going to be very less. So no pap smear is indicated. Okay, usually now she is 65 years, or for example 66 years. Now she have to take any further pap. If the last 3 paps are negative, means there is no need for her to take pap again. So if our last 3 paps are negative, no need to take her again. Okay, take pap again. Our last co-tests, okay, last 2 co-tests, if they are negative, then no need to take pap again. So I have explained you. Okay. In a patient who is having HIV, okay, if a female, if she is having HIV, then yearly screening is indicated. Every year she have to take this, like pap test every year. Okay, if she is having HIV means. So done. FIGO guidelines for the pap is completed. Now what is the adequacy for the pap? The adequacy for the pap is also important MCQ. Now you have done the pap. Okay, you have collected the cells. So what is the adequacy? The number, for example, you get only, for example, 10 cells. Do you think that 10 cells will be enough? Okay, you get only the squamous cells, outside squamous cells. Okay, ectocervix cells. You didn't get any endocervix cells. Will that be enough? See, there is certain adequacy. If you do the conventional pap, okay, conventional pap means by using the IR spatula. I have shown you that wooden stick, right? Wooden stick thing. The IR spatula. With the IR spatula, if you are doing the pap, if you are collecting the cells, then it is called as a conventional pap, okay, which is a little old way of getting the pap, which old way, okay, primitive way. So how many number of squamous cells you should get? Squamous cells means the ectocervical cells. You should get at least 8K to 12K, okay, 8 to 12,000, 8 to 12,000 cells are needed, okay, per 10 high power field, okay. If columnar cells, endocervical cells, even if you get 10, that's enough, okay, done. Okay, for conventional pap, squamous cells 8 to 12K, in between 8 to 12K, and endocervical cells at least 10, okay. And for liquid based cytology, see, liquid based cytology means, I have shown you there is something called as a cytobrush. See, it's liquid based cytology means simple. You are going to take a cytobrush, you are going to put into the cervix, you are going to collect the cells, okay. Now you are going to put it into the liquid, okay, liquid, and you are removing all the debris so that you will be getting a better views of the cells, okay, simple. If you do it with the cytobrush, then it is called as a liquid based cytology. Simple, keep it as simple as that. So in liquid based cytology, how many cells are required? The squamous cells, if you get 5,000 cells, the ectocervical cells, if you get 5,000 cells per 10 high power field, that's enough. And how many columnar cells are required? See, columnar cells is the same thing. Endocervical cells, it's the same, 10 cells. If you have 10 cells, yes, it is adequate. The pap smear is adequate. Okay. So enough cells came for the study. Now, okay, sir, we have done the pap smear. Okay, we have done the pap smear. Now, if the pap smear is coming abnormal, now what you are seeing here is dysplastic cells. Now there is a dysplasia. In certain cells, a dysplasia is seen. Now coilocytes are visible. Now coilocytes are visible means you are little worried. Now see, pap is a screening test. It's not a confirmatory test. It cannot confirm you whether it is CN 1, 2, 3. It cannot confirm you. Or cervical cancer in which stage, it cannot confirm you. So for confirmation, what you have to do, you have to take a biopsy. So after pap, what you have to do is biopsy. Okay, if you can directly see a lesion, okay, if you can directly see a lesion, I will show you the lesions also. If you can directly see a lesion in that area, okay, little cancerous area or dysplastic area, you can take, if lesion is visible, you can directly take a punch biopsy. Okay, you can take a punching machine kind of thing and you can take it, the biopsy, the punch biopsy. Okay, here I have shown the punch biopsy. Okay, see the punches from the lesion which is visible, punch biopsy. If the lesion is not visible, if you cannot see the lesion, then what you have to do? See, then you can go with either colposcopy. Colposcopy is just like, the magnification. There is an instrument called as a colposcope, which is going to magnify the area so that you can have a better visibility. Okay, of small lesions also you can get a better visibility. Okay, by using certain stains kind of thing, you will get a better visibility. I will tell you what is that. And resource poor area, you can do via VILI also. Okay, via VILI, visual inspection under acetic acid. Okay, visual inspection using Lugol's iodine via and VILI. I will show you what is this via and VILI. So simple. If the lesion is not visible, you cannot see anything, then what we have to do? If you cannot see the lesion, then you can go for via or VILI, or you can go with the colposcopy. See, in a multi-specialty hospital, you can go with the colposcopy. If you are not in a multi-specialty hospital, for example, you are in a rural area, then you can go with the via or VILI. So what is this via and VILI, sir? For example, look, now this is the cervix. Now I cannot see any lesion over here. Okay, cervix is looking normal, but in pap smear it is abnormal. There are dysplastic cells. Then what you have to do is you have to put some acetoacetic acid here. Okay, you have to put some acetoacetic, okay, acetoacetates. Now when you put acetoacetates, that dysplastic area, okay, that dysplastic area is going to show white color, aceto-white areas. Okay, so this is called as via visual inspection under acetic acid. Okay, so visual inspection of the cervix with 5% acetic acid. Okay, so dysplastic cells appear white, aceto-white areas near the transformation zone, squamo-columnar junction, the transformation zone. That's the most common site of the cervical intraepithelial neoplasia, you know it. Now what is Lugol's, what is VILI, sir? VILI means same visual inspection. You are not using colposcope, you are directly looking with your eye, for example. Okay, so visual inspection under Lugol's iodine. Okay, under Lugol's iodine, if you put Lugol's iodine, okay, it's the same cervix. You just apply the Lugol's iodine over there. Okay, if you apply the Lugol's iodine, see, this is the normal healthy cells. Normal healthy cells are going to become brown color. Okay, they will stain brown. Okay, the normal areas is going to stain brown, but this dysplastic areas are going to stain this yellow. Okay, so see, visual inspection under Lugol's iodine, normal cells appear brown or mahogany in color. Dysplastic cells are going to appear yellow color. So this is the image based questions which are important. So if the lesion is not visible, how to identify the dysplastic areas? So once you identify the dysplastic area, then you are going to take the biopsy. First you have to know where the dysplasia is. So to know where the dysplasia is, just put some acetic acid, so that if there is dysplasia, that area will turn white color. If there is some dysplasia, put some Lugol's iodine, that dysplastic area is going to show yellow color. Simple as that. Okay, so pathologist work is going to be completed here. Okay, so by using via and VILI methods, you can actually know the dysplastic area. After knowing that, you can take the punch biopsy. Done. Next, management, simple managements. See, if the patient is having CAN1, if the patient is having CAN1, it takes 5 years to convert into CAN3. After getting CAN3, it takes 10 years for the transformation to the cervical cancer, MCQ. So CAN3 takes 10 years for the transformation into the cervical cancer. Okay, sir, for example, the patient is having CAN1. What we have to do? What is the management? The patient is having CAN1, on pap smear, there is dysplasia. Okay, there is dysplasia and you have taken the biopsy, it's a CAN1. So what we will do now? Okay, how is the management? So just do the observation. Okay, do yearly HPV. Okay, ask the patient to come every year and go for the HPV. Okay, yearly HPV. Okay, DNA testing or pap smear every 6 to 12 months. Okay, nothing it's too serious. Okay, ask the patient to come for the pap for every 1 to 6 years, so that we know what's happening. Okay, whether the HPV DNA is increasing or not, whether CAN is progressing into CAN1 or CAN2 or not, we'll know the things. See, CAN1 usually regresses within 1 to 2 years most of the time. Okay, the CAN1 will automatically regress. If it persists, if it is continuously there, then what we have to do? We have to go with the ablation or cryotherapy. Okay, this is the MCQ, cryotherapy. Okay, we are going to do the cryotherapy. We are going to, by using the cold, we are going to totally damage that area of dysplastic cells. Now, for CAN2 and CAN3, which are considered as the HSIL, okay, high grade intraepithelial lesion, okay, high grade squamous intraepithelial lesion. For CAN2 and CAN3, we are going to do the LEAP. LEAP means loop electrosurgical excision procedure. Okay, loop electrosurgical excision procedure. Let me show you what exactly it is. Say here the patient is having, for example, S2 white areas. Okay, if the patient is having CN2 or CN3, what we are going to do is we are going to see by using these wires. Okay, loop. Okay, we are going to remove that area. We are going to just like scoop that area. We remove that area. Okay, this is called as loop electrosurgical excision procedure, which is done for CAN2 and CAN3. If there is a recurrent CAN3, again CAN3 is coming, even after intervening, even after the management, okay, surgical management, again and again CAN3 is coming. Then go with the hysterectomy, because there is a chance that CAN3, 20% of the time, it can turn into cancer within 10 years of span. Okay, so then remove the uterus and cervix, hysterectomy. Okay. See, this is a question which was asked. Laser ablation is the best if CAN extends to the vaginal fornices. Okay, if this CAN, cervical intraepithelial neoplasia, if it is extending into the vaginal fornices, okay, let me show you what is the vaginal fornix. For example, this is the uterus and cervix. Here I am showing this is the cervix. Okay, this is the cervical area. And what is this? Here will be the vagina. Now these are the fornices, right? Vaginal fornices. If the CN is extending into the vaginal fornices, then you can go with the laser ablation. By using the laser, you can cause the ablation of the dysplastic areas. So with this, the cervical cancer, like the CN, whatever I want you to know, it's done, completed. The management of the CN is also completed. Some important points I will explain you. Okay, some important points I want you to know regarding the cervical cancer is, it is the most common gynecological cancer in the world. Okay, the the cervical cancer, the most common gynecological cancer. It's one of the most important cancers that can actually kill the female. Okay, see the cancers in the worldwide. It's one of the most important cancer which can actually cause the death. Okay. Next, the most common gynecological cancer is the cervical cancer. Next, most common gynecological or genital cancer in the Indian women. Indian women worldwide, it's the same, cervical cancer only. Most common cancer in India. See, most common cancer in women in India, it's not, see, gynecological cancer is cervical cancer, but most common cancer in women is breast cancer. Okay. It's the fourth one. Okay, I have shown you. It's the fourth most common cancer. Okay, in the women worldwide. What is the first most common? Breast cancer, followed by colorectal and lung. Breast, colorectal, lung, and cervical cancer. Okay, this is the order. See, the most common cancer, cervical cancer is the most common cancer in the post-menopausal bleeding women. Okay, post-menopausal bleeding women. The cervical cancer is the most common cancer. Okay, it's the most common cause of the pyometra. Okay, pyo means pus, pyometra. Okay, so pus in the uterus, it's the most common cause. The cervical cancer is the most common cause of the pus in the uterus, pyometra. The most common histological variant is, so cervical cancer, I have told you there are two types of cervical cancer. One is squamous cell carcinoma and other is the adenocarcinoma. The most common variety is squamous cell carcinoma. Adenocarcinoma is also seen, yes, we have discussed. Listen, what is the most common site of cervical cancer? The most common site of the cervical cancer, that too squamous cell carcinoma. The most common site is a transition zone. Okay, transition zone or the transformation zone. But what is the most common site of adenocarcinoma? The most common site of adenocarcinoma is endocervix, which is lined by the columnar cells. Endocervix is the most common site of the adenocarcinoma. Okay, this is what I have shown you, discussed already. Squamous cell carcinoma is 80% of the time it is squamous cell carcinoma. 20% of the time it is adenocarcinoma. Squamous cell carcinoma, it is arising from the squamocolumnar junction. Adenocarcinoma is arising from the endocervix. Okay, the subvarieties you can discuss, you can study them in your gynecology, but this is enough. Okay, this is enough from my side. Okay, next, other important points which I want you to know. What are the most specific findings? Imagine there is a female who is having cervical cancer. Now she is having cervical cancer. What are the complaints that she is going to do? The most specific complaint, one complaint is there. Let me tell you what exactly it is. See, it's a post-coital bleeding. I have said you the cervical cancer is most commonly going to be seen in reproductive age group females. Okay, where they are going to get this HPV. What's their main complaint? Without this, they won't give you the question. The main problem is post-coital bleeding, means after having the intercourse, they're going to have the bleeding, because during the intercourse, when the penetration is happening, there is a chance that this cervix is getting affected and the cervical, like the cervix is going to be more friable now. Okay, with lot of blood vessels, with the neovascularization, now there can be a damage to the cervix and the blood vessels can get damaged and there can be bleeding. Okay, so this is the point which I want you to know. There are other things, so bleeding per vaginum. So there are many conditions in which there will be bleeding per vaginum. Okay, but this is the point. Most specific is postcoital bleeding. Okay. Next, what else is the complications? What are the complications seen with the cervical cancer? Okay, imagine there is a female who is having the cervical cancer. What are the complications that are going to be seen? Complications are going to be fistula. Okay, so fistula formations, vesicovaginal fistulas. Okay, abnormal connections are going to occur. Vesicovaginal fistulas, vesicocervical fistulas. Okay, rectovaginal fistulas. Fistulas can be seen. And uremia. The point which I want you to know from this slide, one point is, sir, whoever is having the cervical cancer, they are going to actually die with the renal failure, sir. Okay, the metastasis will extend into the kidneys. The cancer cells will go into the kidneys, can lead to the kidney failure. That kidney failure is the one which is causing the uremia, and that actually kills the patient. So the most common cause of death in a female who is having cervical cancer is actually renal failure. Okay, so these are the complications, like fistulas can be seen, kidneys can be affected, uremia, nephrosis, okay, hydronephrosis, and death. And what else are the questions which were previously asked is, sir, which lymph nodes are affected? Okay, which lymph nodes are affected? Okay, the female is having cervical cancer. The cancer means it will show the metastasis. Metastasis is going to be there. The cancer spreads to the different organs. If a female is having cervical cancer, which lymph nodes are going to be affected? So, see, the lymph nodes most commonly affected are the external iliac lymph nodes. Okay, in the older books, will mention obturator lymph node, but no, it's not the obturator lymph nodes. It's the external iliac lymph nodes are most commonly affected. It's the update. External iliac lymph nodes are going to be most commonly affected in a female who is having cervical cancer, followed by the obturator lymph nodes. If you don't find the external iliac, then mark the obturator lymph nodes. Okay, and how the cancer is going to spread? The cancer is going to spread by direct extension. Okay, it's direct extension to the surrounding areas. It will also show lymphatic as well as hematogenous spread. Okay, most of the time this will be in your exams. So hematogenous spread via the blood, it will spread to multiple places. Okay, hematogenous spread is going to be seen, and external iliac lymph nodes are the most common lymph nodes that are affected. And what is the most common site of metastasis? So the cervical cancer is going to metastasize especially to the lungs. Okay, that's the most common site of hematogenous spread. That's the question which was previously asked. Okay, least common site of metastasis is ovaries. So with this, the points which I want you to know from pathology point of view are completed, sir. Okay, I highly recommend you to go and see the cervical cancer stages. Okay, what are the stages of cervical cancer? Stage 1, 2, 3, 4. Okay, that's also very high yielding area which I am not going to discuss here. That's actually a topic of gynecology. Okay, now after that, let me discuss about the next topic, that is called as the endometriosis. So what are the important points which you need to know? Okay, I will be discussing only the important points. Endometriosis, sir. What exactly is endometriosis? In the name itself it's there, endometrium. Okay, endometriosis, problem with the endometrium. So where the endometrium was supposed to be? Endometrium was supposed to be in the uterine cavity. It was supposed to be present within the uterine cavity. If the endometrium, see, imagine this is the uterus. This is the place where endometrium was supposed to grow. Okay. What if the endometrium is growing in the fallopian tube? Or what if it is growing in the ovary? Okay. So then it is called as ectopic endometrium or abnormal endometrium. That condition is called as endometriosis. So endometriosis is a disease in which tissue similar to the lining of the uterus, that is endometrium, grows outside the uterine cavity. It's simple, endometrium is growing outside the uterine cavity. What is the most common age group that is affected? Reproductive age group. Okay, reproductive age group. Cervical cancer, what is the most common age group that is affected? Reproductive age group. Okay, what is the cause of cervical cancer? HPV. Then what is the cause of this endometriosis, or in which persons you can have this endometriosis? I will tell you the risk factors, but you should get a question. Sir, endometrium was supposed to be present within the uterus, right? Then how it is growing outside the uterus? Okay, how it is growing outside the uterus? See, there are certain theories. Okay, theories explaining the endometriosis. How endometrium is coming out of the uterus is, look here. Now what's happening? The endometrium is shedding, right? The endometrium is shedding. Okay, endometrium is getting shedding. So during that process, see, some endometrium, okay, some blood can go like this via the fallopian tubes. So now this endometrium, it is coming into the peritoneal cavity. Okay, this is called as menstruation, but back menstruation, retrograde menstruation. So what are the theories which explains the endometriosis? The theory is, first theory is Sampson's theory. Sampson's theory is retrograde menstruation. Okay, so that retrograde menstruation is going to cause the implantation. So that endometrial cells which got menstruated into the peritoneal cavity, now they are getting implanted into the peritoneal cavity. They get implanted onto the ovaries, they get implanted in the area of the pouch of Douglas, and there they are growing. Okay, so that is the one theory. The second theory is metastasis theory. Okay, benign metastasis theory, which means these endometrial cells via the blood and lymphatics, somehow via the blood and lymphatics, they are showing the metastasis. Means they are going into the different parts of the body, and there they are growing. This is called as the metastasis theory. Okay, distant metastasis. It was proposed by Halban's theory of metastasis. Okay, distance metastasis. Sampson's theory of retrograde menstruation. And the third theory is metaplastic theory. Metaplastic theory means, you know it, changing of one type of cell into the other type of cell, one type of epithelium into the other type of epithelium. Simple, the lining epithelium, for example, like this, the lining epithelium which is there in the lungs. Now it got changed, metaplastic change into the endometrial cells. Okay, so these are the different theories which explains why there is ectopic endometrium. Okay, in one of the exams, this question was asked. So Sampson's theory, the famous theory that retrograde menstruation is the one causing the endometriosis. So it fails to explain distant endometriosis. For example, there is a chance that endometriosis can happen in the lungs. There is a chance that endometriosis can happen even in the premenstrual females. For example, say, if there is a retrograde menstruation, that endometrium is falling in the peritoneal cavity, and there it should grow. Then how it is coming to the lungs? Okay, so Sampson's theory, that is a retrograde menstruation theory, cannot explain how endometriosis is happening in the lungs or in distant sites like eyes or in the nose. Yes, possible, endometriosis is possible. Okay, growing of the endometrium in the eyes, nose, in other parts of the body is still possible. So Sampson's theory failed. The retrograde menstruation theory fails to explain endometriosis in different distant organs. Even in premenarchal females means, for example, 8-year-old girl or 9-year-old girl, she doesn't even have the menses, but still she is suffering with the endometriosis without even menstruation. Then how can retrograde menstruation is possible? Okay, so Sampson's theory have these two limitations. It cannot explain endometriosis in premenarchal females, and it cannot explain endometriosis in distant organs. Okay, now see, the point which I want you to know is, see, almost 7 to 80% of the women, most of the women, they will have retrograde menstruation. But do you think all these women are having this endometriosis, growing of the endometrium outside the uterine cavity? No, if there is endometrium outside the uterine cavity, the immune system will be going there and removing that debris material, whatever is there. Even though 80% of the females are having this retrograde menstruation, only a few will develop endometriosis. Why? Because though that female who is having low immune status, okay, that female who is having low immune status, which means she is immunocompromised, one prerequisite which is needed, she is immunocompromised and she is having hyperestrogenic states, means she is having lots and lots of estrogen in her body which favors the growth of endometrium. So two things are required, just not the retrograde menstruation. What she requires is a hyperestrogenic state. So all hyperestrogenic states means that conditions where the estrogen levels are going to be so much high. So hyperestrogenic states and immunocompromised females are at risk of developing this endometriosis. Okay, so these are the points which I want you to know. So some now pathological important things. Endometriosis, yes, it can occur anywhere in the body. It can occur anywhere in the body. But what are the most common sites? The most common sites of endometriosis are ovary. The first most common site is the ovary. So if you look at an ovary, see, ovary, inside the ovary, this endometrium is growing. Okay, endometrial tissue is growing, and these ovaries are now called as a chocolate cysts. Okay, now in this ovary, there's a lot of this fluid that's getting accumulated because of this growth of the endometrium. So it's just how it's looking like. See, when you just make an incision, see how that fluid is coming out. Okay, so it's going to be called, these are called as a chocolate cysts. Okay, so most common site is ovary. It can occur anywhere, sir. It can occur in, say, abdominal wall, lungs, pleura, eyes, anywhere it can occur. But the most common site is ovary, followed by cul-de-sac. You know the cul-de-sac, right? It's a pouch of Douglas. Okay, it's a pouch of Douglas. Most common extra-pelvic endometriosis. Most common site for the extra-pelvic, outside the pelvis. It's the sigmoid colon. Least common site is brain. Okay, least common site is brain cells. So it can occur anywhere. It can occur anywhere. That's the point which I want you to know. So what is vicarious menstruation? This is little like interesting thing. Now imagine there is a female who is bleeding through her eyes every month. Every month, the time of her menstruation, the time that she is bleeding through her eyes are like coinciding. Okay, at the same time she is menstruating, at the same time she is bleeding through her eyes. Why? Because she is having endometrium. See, endometriosis is happening in her eyes. Okay, so that endometrium is also going to shed. Okay, so same endometrium through the uterus and the endometrium through her eyes are all shedding at the same time. That's causing the little bleeding. Okay, this is called as a vicarious menstruation. So cyclical bleeding, it can occur from nose or it can occur from eyes exactly at the time of menses. Okay, that's called as a vicarious menstruation. I have said you what are the important risk factors for endometriosis. The important risk factors are all the hyperestrogenic states. Hyperestrogenic states. For example, say early menarche. Early menarche means, for example, let's see how early menarche is the one responsible for the endometriosis. How, sir, if you ask me? Early menarche means early menses. Early menses means more the time she is going for the menstrual cycles. More the time she is going for the menstrual cycles. Okay. For example, normally she have to start her menarche 14 years of age. For example, let's take 14 years of age. 14 years to 50 years, for example. Now, if she is starting her menses by 8 years of age, means 8, 9, 10, 11, 12, 13, 14, 7 years of extra menstruation is happening. So, there is a chance that more retrograde menstruation, more chances of endometriosis. So, early menarche or late menopause, same thing. Late menopause, she is menstruating till 60 years of age, means more number of menstrual cycles, more chances of retrograde menstruation, more chances of endometriosis. First degree relative with endometriosis. True, if the mother or sister, if anyone of the first degree, right, direct bloodline, if they are having endometriosis, there is a chance, it is seen that there is a likely chance that this female is also going to have endometriosis. And some important points which I want you to know is Mullerian anomalies. Okay, that reproductive tract is not properly formed. Because of that, if the, say for example, if there is a cervical stenosis, if the tract, if it is narrow, there is a chance that there can be retrograde menstruation. Okay, so nulliparity means she is not having any babies, she is not going for the pregnancy. If she is not going for the pregnancy, means actually during pregnancy 12 months break, 12 months break of menses. After delivery there is almost 6 to 7 month break of the menses because of the lactational amenorrhea. So almost there is a 1.5 year period of no menses. So if a female, if she is pregnant, means 1.5 year break from the menses. If she is nulliparous, means continuously menses, more chances of retrograde menstruation, more chances of endometriosis. Okay, prolonged menstruation means normally menstruation should be happening for 5 days. Okay, the first 5 days of the cycle. If she is having menstruation for 7 days, 8 days, more bleeding, more chances of retrograde menstruation, more chances of endometriosis. Okay, and shorter lactation intervals means she is not lactating, for example. If she is not lactating, after delivery, she is not lactating. If she is not lactating, what happens? She is not lactating means again immediately menses will start in her body. Menses will immediately kick in. So, menses, retrograde menstruation, chances of endometriosis. So, it's a risk factor, true. Okay, and shorter menstrual cycles. Okay, so shorter menstrual cycle means every month she have to once menstruate. Okay, a female have to menstruate every, like, once in every 28 days. Okay, like once in every month. Let's put it this way. If she is having menses for every 15 days, for example, for every 15 days, means the number of cycles are doubled. In a year, she was supposed to menstruate 12 times, but now if she is having cycles for every 15 days, she will menstruate 24 times. Means more number of cycles, more chances of retrograde menstruation, more chance of endometriosis. Okay, and it is seen that in white race, especially this endometriosis is going to be seen in white race. The fibroids, uterine fibroids are seen in the black women. Fibroids are seen in the black women, but endometriosis is most highly seen in the endometriosis because most of the white women from the developed countries, they will be like, they will be high estrogen states. Okay, they will be usually obese and they will be having high estrogen levels, and that high estrogen levels are the ones which are the prerequisite for the growth of this endometrial tissue outside the uterine cavity. Okay, so endometriosis risk factors all I have explained. And what is the investigation of choice? The investigation of choice, see there the screening test for the cervical cancer is pap smear. Here the investigation of choice is laparoscopy. You just put a laparoscope. Okay, you just put a laparoscope into the abdomen, and what you can see here is these areas, this red color areas, these small red areas you are seeing, right? Those are the areas of endometriosis. Okay, those are the areas of the endometriosis. What you can see here is the cul-de-sac. Okay, for example, let me show you like this. See, this is the normal uterus. Okay, here are the fallopian tubules. Okay, and what you can see here is the pouch of Douglas. Okay, here is one ovary, here is one ovary. This is something normal. Let me show you how the laparoscopy is going to view in a female who is having endometriosis. Look here. See, now in her ovaries, you can very clearly see this endometrium, ectopic endometrium and endometriosis, chocolate cysts. Okay, so what you can see here, chocolate cysts, which are example of true cysts. That's the point which I want you to know. See, in pathology, which I want you to know is associated with this chocolate cyst. If a female is having chocolate cyst, there is a chance that she can develop clear cell carcinoma of the ovary or endometrioid carcinoma of the ovary. Okay, so yes, chocolate cyst increases the risk of ovarian cancer. Okay, so what you have to do? What is the management? So you cannot do medical management. You cannot treat it medically. Laparoscopic cystectomy. That's a question asked. Okay, laparoscopic cystectomy. Via laparoscopy, you have to remove both the ovaries. Okay, laparoscopic cystectomy. See, this is the patient who is having a very severe endometriosis, where there are so many adhesions because of the inflammation every time. Okay, the endometrium is getting shedded over there. That's causing the inflammation. Because of that, so much adhesions are seen. So a powder gun appearance, like black color, like gunpowder, powder gun appearance or gunshot appearance is seen due to hemorrhage. That hemorrhage is happening over there. The blood is getting degraded and the iron pigment is coming. The hemocysteine is coming. Because of that, you can see the gunpowder or gunshot appearance is going to be seen. And what else you can see is because of that endometrium also will shed. So because of that, you can have the bleeding in the peritoneal cavity. Peritoneal cavity contains this fluid. Okay, the fluid accumulation in the peritoneal cavity, especially in the pouch of Douglas. The points which I want you to know is laparoscopy is the gold standard. If you do the laparoscopy, you will see the gunpowder appearance or the gunshot appearance. You can see the chocolate cysts. You have to remove the chocolate cysts, otherwise they can turn into clear cell carcinoma or endometrioid carcinoma. You can see some fluid accumulation also. Now, what are the most common symptoms? Okay, see, these are the keywords. Okay, these are the keywords. What is the most specific symptom in a female who is having cervical cancer? In a female who is having cervical cancer, it's a post-coital bleeding. If she goes for the intercourse, she is going to have the bleeding. That's the key word. Now, if a female is having endometriosis, do you know what is the chief complaint? She is going to have a very severe pain, dysmenorrhea. Very severe pain is going to be seen. Dysmenorrhea is going to be seen. Okay, the most common symptom is going to be pain. That's a secondary dysmenorrhea. Okay, and also she is going to have the infertility. Okay, because there is a lot of inflammation going on in the pelvic area, and also ovaries are going to be affected. Most common sites, ovaries. Okay, so that's the one thing. And not only that, she is also going to say that she is having dyspareunia. Okay, so one thing, pain during the menses. Okay, she is going to suffer with infertility. If she is trying to get conceived, it's not going to occur because inflammation is there in the pelvic area. Inflammation is going to cause the adhesions. Okay, unnecessary adhesions are coming. That adhesions actually causes the distortion in the tubo-ovarian relationship. See, imagine this is the ovary, this is the fallopian tube. Actually, the ovary and fallopian tube are in a very close relationship. Now, the tubo-ovarian relationship is going to be distorted because of these adhesions. Okay, because of the inflammation, severe inflammation, whatever is happening because of this ectopic endometrium. So, there is infertility. And why dyspareunia, sir? Dyspareunia occurs because here I have shown you, see, for example, now there is intercourse that is happening. I have said you, see, this is a pouch of Douglas. Okay, see here, this is the pouch of Douglas, right? That is getting inflamed. Okay, the pouch of Douglas is involved in the endometriosis and that is getting inflamed. So all this area is actually inflamed area, which is so much painful. So whenever the coitus is happening, whenever the intercourse is happening, so this area, the posterior wall of the vagina is getting involved. The posterior wall of the vagina is actually forming the wall for the pouch of Douglas. So during intercourse, there is a chance that she can have the pain. So most common symptoms are pain, infertility, as well as dyspareunia, and these patients are going to have menorrhagia. Excessive hemorrhage is going to occur. So hyperestrogenic females, right? So hyperestrogenic females means more endometrial proliferation within the uterus also, more endometrial proliferation. More endometrium means more bleeding. Menorrhagia can be seen. Okay? So these are the points which I want you to know. Okay, so they have said you that infertility. Why infertility? Due to distortion in the tubo-ovarian relationship. And what else, sir? What else? See, what else I want you to know is from the pathology. Pathology, so these patients are going to have elevated levels of CA125. Okay, these patients, this is actually a marker. CA125 is a marker. See, CA125 levels in the blood, okay, is going to be elevated. But important point is CA125 levels are also going to be elevated with other conditions like uterine fibroid, pelvic inflammatory disease, pelvic TB, and epithelial, okay, ovarian cancers, epithelial ovarian cancers. In all these conditions, CA125 levels are elevated. So this is not something specific, yes, but they are elevated. But important point which I want you to know is, see, because of the adhesions, unnecessary adhesions, so many endometrial implants, that's causing inflammation, leading to formation of this fibrous strands, adhesions. Because of these adhesions, do you know what happens? See, the uterus, which was supposed to be antiverted and antiflexed, okay, actually the uterus was supposed to be antiverted and antiflexed like this. Okay, it should be, see, imagine this is the urinary bladder, this is the uterus. Uterus is like this, antiverted and antiflexed. Now, because of these adhesions, the uterus will become like this. Now, don't think that the patient is having two uterus. No, it's the same uterus. Because of this unnecessary adhesions, it's becoming retroverted. Okay, it's going back like this, retroverted. So, what you will say is a retroverted, fixed retroverted uterus. Okay, and because of the adhesions. And what else, sir? See, let me show you one image. Okay, this image. See, these are the uterosacral ligaments. You can very clearly see here, these are the uterosacral ligaments. Dekho. See, this is the cul-de-sac, right? This is the cul-de-sac or the pouch of Douglas. Here, this is uterosacral ligament. There is a chance that, see, due to the retrograde menstruation, I have said the second most common site of endometriosis is cul-de-sac. Okay. Now, these endometrial implants will also fall on the uterosacral ligaments and they will also grow. Okay, these endometrial implants will most of the time, 99% of the time, they will also be seen on the uterosacral ligaments. So, if you do the examination digitally, you can feel this. Okay, digitally you can feel this. There is a nodularity. Okay, the uterosacral ligament nodularity, you feel like a cobblestone kind of, like, feel, cobblestone kind of feel. Okay, when you do the examination, digital examination, you can feel this. This is something scenic phenon. Scenic phenon means 100% it will be there, without which it will not exist. Without this uterosacral ligament nodularity, endometriosis does not exist. That is scenic phenon. So, what is the scenic phenon of endometriosis? Uterosacral ligament nodularity. On the uterosacral ligament, you can feel the nodularity because of the growth of this endometrial implants. Okay. So, these are the points which I want you to know regarding endometriosis. The treatment of endometriosis, you can do it in your gynecology. Actually, this is a so painful condition. So, you can do treatment with the non-steroidal anti-inflammatory drugs, and you can give the progesterone infections, high dose progesterones, which will cause the atrophy of the endometrium. You can actually stop the menses in these females who are having severe pain. Okay, they cannot bear this pain. It's like a torture for them every month. So, what you can do is you can simply stop the menses. You can simply stop the menses. Okay, for months together, you can stop the menses. So, without menses, no pain. Okay, by giving high dose progesterone injections, you can actually stop the menses. Okay, so these are the points which I want you to know regarding endometriosis. What you will see in the lab, CA125 levels are elevated. So, I am stopping the session for today. In tomorrow's class, let's do more gynecological disorders. Hope the class is helpful. See you tomorrow. Thank you.